Hello and welcome everyone. Thank you very much for joining us this evening for our online talk on knee osteoarthritis and the benefits of arthrosamid. I'm Katie, one of the members of the marketing team, and I'm delighted to be joined by Mr. Tofunmi Oni, one of our consultant orthopaedic surgeons here at the Horder Centre. Mr. Oni specialises in hip and knee procedures, including hip replacement, knee replacement, meniscus tear repair, knee arthroscopy, and revision hip replacement, alongside his expertise in knee injections. I'm also pleased to be joined by Jonathan Thomson from Contura, the company behind Arthrosamid, and he'll be sharing his expertise on the product with a particular focus on the research evidence and published data surrounding its use. We have a great hour ahead of us, so before I hand over to Mr. Oni and his presentation, I just want to remind you that this is a live recorded event and the recording will be emailed to you tomorrow. We won't be able to respond to raised hands directly, but do drop any questions that you have into the Q&A box for us to address during the segment later on. But once again, thank you all very much for joining us, and please welcome Mr. Oni.
Hello, everyone. I hope everyone can hear me. I'm sure the guys will stop me if anyone, if we can't. My name is Tofunmi Oni. I'm one of the, as Katie said, one of the hip and knee surgeons here at the Horder Centre. I'm going to talk today about arthrosamid, specifically in the knee joint, because that is what it's currently licensed for in this country. And we I'm going to start just by going through a bit of an overview of who we use it for. And I thought the best way to start is to talk a little bit about arthritis itself, and not just what it is, but how it causes pain, and therefore how we can target that pain with treatments, and specifically arthrosamid with that. So what is knee osteoarthritis? Well, it's the thinning of the protective cartilage layer that cushions between the bones at the joint. And often it is something that happens with wear and tear, happens over time. But it can also happen after things like traumatic events, or actually some other sort of joint type of diseases. Now, when that protective layer thins, it often leads to increased bone stress, as you can imagine. So it's depicted on the picture there. That white layer, that shiny layer, is the cartilage, which should be the equivalent of essentially ice on ice. That level of friction, which is nothing at all. And as it starts to thin, the bone underneath it gets exposed to more stress. The whole situation becomes a bit more irritable, which drives inflammation in the joint. And over time, what I try to convey to people is it's not just the arthritis isn't just disease of just the cartilage, but the entire joint. And so eventually engulfs all of the ligaments around, and the synovium, which is the lining of the joint. So the tissue that lines the joint as well also become diseased. So here's a key question. Why does it hurt? Well, with less of the shock absorbing sort of cushioning, you do get mechanical stress, which causes pain just from overload of the bones underneath it. That can drive pain. But also a key part of it is that lining, the synovium, becomes inflamed. And I'll go into a little bit more detail about how this happens. But the key message here is that inflammation of the synovium generates a stiffer environment, which can activate sort of pain. So something that very commonly I hear from my patients is, well, my joint has less movement, and this is part of what starts to drive that process. So if we look into it with a little bit more detail, so why does knee osteoarthritis hurt? Initially, it starts off at the top there. So you've got a cycle that starts at the top, where you have thinning of the cartilage, which breaks down into smaller fragments and pieces. Now, these pieces are, it says there, a very posh word, phagocytose, which means that the cells of the lining of the tissue eat up all the debris. And that is a pro-inflammatory process. And so they start sort of, releasing inflammatory chemicals that drive the production of certain enzymes that keep that inflammatory process going. Those enzymes then break down further cartilage, and the cycle then, continues. Um, Now, after that process happens for a while, this is a key slide to what my point was previously, which is how do you get stiffness? Now, that process from the previous slide happening over and over again drives a fibrotic or fibrosis, we will say, which is akin to a scar forming when we cut ourselves. Eventually, you get inflammation, and then a scar eventually forms. Well, that process is similar to what's happening. And as the scar sort of forms, or we'll say fibrosis happens, the synovium becomes more and more stiff, and that stiffness activates certain sort of channels of nerve cells within the joint, which then fire off more pain. So the key message is there are multiple different ways in which you can get pain with osteoarthritis. But the one of interest today is very much this process of pain that's generated by the synovium getting more and more stiff. So just to take a step back and look at the current treatments that we have for knee osteoarthritis at the moment, the first point is what we would group as conservative measures. So exercise and physiotherapy, those things tend to build the muscles around the joint to help to offload the joint. Same as weight loss and weight management, and analgesia. So again, especially things like anti-inflammatories can help with the process that or calming the process that I spoke of before. The next point on there is injections, and I'm just going to hold fire there, and we'll go into that in a moment. But very much when all other avenues are exhausted, then surgery in the form of a knee replacement is usually the most reliable long-term method. But I'm most interested for today's purposes in that middle point, which is injections. So if we look at current injection treatments, by far and away the most commonly given the treatment is steroid injections. And what so many people experience with this is it works extremely well, usually extremely quickly, but it only lasts for a certain amount of time. And generally speaking, the chemical effect of a steroid, which is working on those that anti-inflammatory or on those inflammatory chemicals that I spoke of earlier to calm them down, is something that works very well, but works for as long as it essentially takes the body to break it down and clear. And so therefore, although it works well, it does not work for a long period of time. Um, Same with other types of injections like hyaluronic acid, otherwise those sort of things like Durolane, often acts as a lubricant and shock absorber. But these also break down over time, and the body clears it, which does not lead to long-term effects of the injection. The last injection I'll speak of before we go to arthrosamid is PRP. So injection, which is a type of therapy where the blood of the patient is harvested and spun down to concentrate a specific layer of cells that are known to have anti-inflammatory properties, and that is then injected back into the joint. But this has exactly the same problem as the other two, which is the body tends to clear what is not native to the actual joint. And so this is a summary of those, why those injections are limited. They work through chemistry, not structure. So the chemical effect is something that's always going to wear off because the body gets rid of it. They don't change the actual lining of the joint or the cartilage in any way. And like I said, the effects are reduced over time as the chemicals are absorbed. And that often can lead to repeated injections, which can have issues of its own. So introducing Arthrosamid. So what is it? Well, this is how it's described: a single injection treatment for osteoarthritis. It's described as the first and only synovial implant for knee pain. Now, I'll go into that in a little bit more detail, but it is essentially a polyacrylamide hydrogel, so it's 2.5% of a hydrogel. The other 97.5% is water. But what that specific combination does is create a specific structural gel that is then injected directly into the knee joint. This is a slide that I think I will let Jonathan from Contura talk about. It's just to say that, this is not a new therapy. It's new to this country in a very specific way, but it has been given in various ways in different countries in different circumstances for the last 25 years. But I believe Jonathan will say a little bit more about that later on. So how is arthrosamid different? Well, it's injected to the knee joint. Well, that's not different to any others. It says it moves naturally into the joint lining, and so it very much targets the synovium that we spoke of before, and that synovial tissue it becomes integrated with the tissue over a 4 to 6 week period, which incidentally is the period that we not before we'd expect things to this injection to start working. Um, but very much that integration into the tissue eventually will make that synovium softer, more elastic, and less painful because it's driving less of that mechanical receptor stiffness nerve pathway that I spoke of before. But let's talk about that in again in a little bit more detail because often people will ask, well, it becomes integrated in tissue. Is that a problem? And the answer is no, it isn't. In fact, that is the key to the longevity of it. It becomes integrated on microscope. It looks just like what we call the extracellular matrix of tissue. So the body's own tissue, it very much mimics the structure. And what that does is create a scaffold for the body's own cells to grow into. And so rather than reabsorbed, it very much gets assimilated and therefore has an effect that is much longer than the average injection, which is something we'll go into. Um, so I know I've seen some of the questions already from that some people had for us, and I know some of this will answer it. The first thing people always want to know when they come and see me about arthrosamid is, well, will it work? And the answer is there is no hard and fast yes or no. There is a sliding scale of things that make it more likely to work and less likely to work. And that's very much due to all the data that's come out, the Contura have done. Most of it understood, some of it was still understanding, even though it's been given, across parts of Europe for 20 years in different ways. The key point that this slide is making is age is a large factor towards the response rate. And so the studies were done found that 80% of responders where it worked were very much in individuals who were under 70. Now, that's not to say it will not work for people over 70, but it's the likelihood of it working is biased towards younger individuals rather than older individuals. Um, And that then goes on to my next point. So all of the data that's been collected so far has been essentially crystallized and analyzed to um, to get to a point where you have certain points that you can say with a high level of accuracy that it is more likely to work if you have these specific things. And these four things are key. One, the top one says knee swelling, and knee swelling is essentially a surrogate for inflammation, and we know that the arthrosamid works on that inflammatory pathway. And so, if you have the specific type of arthritis, osteoarthritis, where there's more inflammation, then you tend to have more swelling, and therefore it tends to work more. Um, if you have mild or moderate arthritis as opposed to severe arthritis, it tends to work with more regularity. And that makes sense because the more severe your arthritis, the more that inflammatory process is, and the more, I suppose, the gel has to be able to deal with. And that's similar to a body mass index. So we talked about weight earlier on and weight loss as a way of controlling symptoms and the conservative measures. But we know that if your BMI is over 35, then again that drives more of a more weight through the joint, more force, which breeds more of an inflammatory response, and therefore makes it less likely to work. And again, age, which I spoke about on the last slide, it is key. The more younger or biologically active a patient's cells are, then the more likely it is to work. Having said all of this, the data that's come out of Contura, I'm sure Jonathan will touch on, show, and I found this in my practice, is if all these things are ignored and it's given to older individuals and maybe with a little bit more severe arthritis, we know that the response rate is roughly 70% if people aren't being if these four things aren't being adhered to um, really sort of tightly. And if they are being adhered to tightly, then it's upwards of 95% chance of reducing symptoms significantly. And not just reducing symptoms significantly, but it's the longevity that I'm the most interested in, because we know that if it does work, then it tends to work for a long period of time, which I'll touch on in a minute. So the question is, who may also consider it? Well, yes, that last slide looked at the four points of individuals that if you have all four of those things, it's the most likely to work. But the fact is, anyone can try it, as it were. But people who've tried physiotherapy and all other injections or conservative measures, very much arthrosamid is an option, or indeed people who do have severe arthritis but are not quite ready for a knee replacement or not fit enough for a knee replacement from an anesthetic point of view. You may also consider arthrosamid. How long does it last? Now, there's a very good slide that's coming up, and I know certainly Jonathan will touch on this later. The clinical benefits certainly are shown have been proven up to 5 years at the moment, and I know there are certain clinical trials that were started over 5 years ago where the individuals are still being followed up at the moment into 7 years, where a significant amount of people are still getting benefit from that. And so, yes, there may be a situation where no, it does not work in everybody, but if it does work, then we'd expect it to work for around about the 5 year mark, give or take a period of time. So it is not a short-term painkiller. It's very much a long-term treatment and something designed to change lifestyle. And that's exactly what this busy slide is saying, which is the it's essentially looking at the pain score of individuals over time at the point at which they had the injection, and you can see very much the pain drops and stays down over that five-year period of time. So the key take-home messages, because I don't want to harp on for too long, is knee osteoarthritis, is because of a loss of cartilage, but it's also a lining of the joint disease as well as the loss of cartilage disease. And most injections give temporary relief. Arthrosamid targets the lining of the joint itself and the ability of the lining of the joint to generate pain. And although it's best suited to selected individuals, it very much has a rate of 70% of people that do work, or higher if you're in that select group of people that have those four things that we spoke about. So I'm gonna just stop there and just hand over to Jonathan, who's just gonna go into a little bit more detail about the history of Arthrosamid, where it started, why it's just around now and not from a while ago. And then after Jonathan has says his presentation, then we'll take questions at that point. Thank you very
Hello
much.
and good evening, everyone. So, yeah, if my job here is just basically give you a bit of a history lesson on the gel, a bit of a summary of the clinical data, and then again we'll answer the questions on the back end of this as well. But when I joined the business 3 years ago, again, one of my questions when I was looking to join, but also yourself as patients that are suffering from osteoarthritis is, well, how long has it been around? And again, with this gel has actually been used for 25 years within the human body. So again, it's been used pretty routinely for aesthetics. It's also used in stress incontinence, which has been proven very biologically safe. But also how it really got into osteoarthritis, and I'll show this a bit later on, is it's a really massive product in the elite equine space. So a lot of the horses, both show jumping and polo ponies, have been treated with this gel. So all in all, over the 25-year history of Contura, over 2 million syringes are in horses and humans globally. And again, it's been proven a very safe product. When I refer to Arthrosamid, so again, the license for this technology, as I'll show you in the next slide, was only granted in 2021. But actually, the company originates from Denmark. And over in Denmark, where they started treating these racehorses, numerous sort of patients, generally there were people that were involved in the equine space, so racehorse trainers and jockeys started to request treatment when they saw the impact it had in their own animals and wanted it in their own knees. So we're very proud and happy that we've treated over 26,000 patients with this technology. So again, we've got this evidence to show the pain relief can last 5 years and counting at the moment. But actually, even though the license in 2021, we've moved this technology for 15 years in knees. So again, just to touch on a couple of points in the timeline here. So again, we've been generating evidence for a long period of time now within the business. But particularly when I talk about the human application for knees, again, we started treating humans in 2010. So that's before it had its license. I'll show you a bit of a snapshot of some of the data in the next sort of few slides. But again, being
Sorry, Jonathan. Sorry to
Cool.
interrupt. I'm not sure if you're sharing your screen. Would you mind sharing your screen?
Of course I can, yeah. It's
Um, I'm not sure if everyone else can see it. It's just not me.
Sorry, I'll just jump in. I could actually see that. So
Oh, okay.
That's
I'm
all right.
not sure.
You can go back
I
in again,
th
it's no problem.
I think we're okay, John. I'm not sure if it's
Okay.
Shout me
happening
if
on
you have
your
any
screen.
problems, but
Yeah,
yeah,
cool.
there we go.
Apologies.
So back to the timeline. So yeah, first human treated in 2010 in the knee application. And there's this period here, and there's a lot of interest because of an equine paper I'll show you, which showed this direct correlation, as Mr. Oni said, about a fusion, so that pain and swelling you can get when your knee gets angry. And they showed that after 2 years, there's a big correlation between those elite racehorses after running, their fusion was decreasing, their pain was improving. We're on this sort of huge sort of journey to basically discover more and more about the gel, and we're still on that journey now. So again, you'll see we've got these various studies, which I'll give you a whistle-stop tour of later on. And again, the names Daisy, Ida, and Rosa, and Luna just refer to summaries of those studies. But again, we're really proud and happy that not only do we have two studies now showing 5 year efficacy, but also we're really proud and happy that we can show data from our own NHS, from some study work that's concluded, to show that this has been a really successful product to help patients within our own health system treat their needs of osteoarthritis. Again, I'll touch upon really quickly because it's really important when you have any intervention that it's safe. We want to be able to provide you with pain relief, but it needs to be safe as well. And again, we're very confident and happy that over our 25 years of a business of putting this gel in, it's been proven safe, but we've shown that as well within the knee world. So again, because we've used this gel for a period of time, over a decade in Scandinavia, we can evidence and show from going back over some of these patients that the gel is safe long term. It doesn't appear to burn any bridges for surgery if you need it later down the line. But again, our aim is to provide you with long-term pain relief from one injection. So again, it works in a very different way, and I won't go into loads of detail about this, but this is a really exciting point because actually the current options we've had available until now have typically either been a short-term injection, the other conservative treatment options we have, or surgery. So there's been this big gap in between where those patients want to avoid surgery or want to basically prolong time in their own knee before having surgery. Arthrosamid really fills that gap for us. But really briefly, how it works. Again, it's just simply injected into your knee. So you come into the Horder Center, you take some antibiotics just because it's an implant going into your body, and then you basically wait around for them to reach concentration. This gets injected into your knee space alongside some anesthetic. And what happens over time, your lining of your joint acts like a big sieve, and it filters all the particulates within your knee, including the arthrosamid. Because of the sort of the construct of the gel as mentioned by Mr. Oni, nothing can break the gel down. There's no enzyme that can break the gel down, and the particle sizes are very large. So what happens with this gel? It lives and exists within the sublining of the knee. And in simple terms, what arthrosamid does, I mean, Mr. Oni mentioned this fibrosis, which we're very familiar about with other tissue across the body. And what this does, this helps that stiffened fibrous membrane become more elastic. Becoming more elastic, that lining then starts to have increased amounts of flexibility. So again, the aim is to basically increase your elasticity of your lining of your joints, and by doing so, reduce your pain that your body receives. And again, just touching upon, I think it's important just to sort of to point you in some direction of some evidence and information. And again, there's multiple great podcasts you can listen to. So, for example, Professor David Hunter from Australia, there's an amazing podcast called the Joint Action Podcast, which summarizes very neatly and very eloquently some of the data and research that is current with osteoarthritis. And again, the key points really here we're trying to show is that osteoarthritis isn't just purely this wear and tear of the bone. And again, that might go some way to explaining why with knee replacements, despite it's a great operation for many, about 15 to 20% of patients are unhappy. Even though we've replaced the bone, they're still getting pain generated from their knee. Now, again, we've mentioned there's various structures that basically can generate that pain, from tendons, ligaments, bone to cartilage. And again, we have good solutions, particularly look at bone or menisci and ligaments to repair these surgically or to manage them conservatively. But again, we are the first and only synovial-based implant which doesn't degrade like the other injectable therapies in the market. And because of this and the mode of action, this is why we're getting this long-term pain relief from these patients that are being injected with arthrosamid. Now, another thing I wanted to introduce the concept is that actually knee osteoarthritis isn't just one disorder. There's actually multiple types. And the reason this is important, this is why you need to go and see a clinician like Mr. Oni to basically be able to tell not only what's driving your pain from a structural perspective, but also the makeup of your own disease. They can then select the right treatment for you as a patient. So moving on just to give you a bit of a commentary about some of the clinical work that we've undertaken, and this is an evolving landscape that we're continuously studying as well. What this graph shows is on the left-hand side, that axis there with the minus numbers in the green area, that's shown a reduction in a survey called the WOMAC pain score, which is a very renowned survey for assessing knee pain for patients of osteoarthritis like yourself. Now on the right here, you'll see time. If it's in the green zone, this means it beats the minimal clinically important difference for the treatment. Now green is good, red is bad, as we know. And here you'll see that all our studies follow and they make sure they're in the green zone all the way out, and the unique element is even at 5 years, in these two studies, the black and the blue line, patients are still achieving a statistically relevant and significant level of pain at 5 years, which is unparalleled and unlike anything else. Now, a couple of other key points to point out. So we've now got this yellow line, which we just plotted onto our graph. Now, this is called the LUNA study, and why we're so excited about this is it was a multi-centre European study that also included 2 NHS sites that volunteered patients through. And again, it's really reassuring and pleasant for us, particularly us in the UK, when you can see not only is the pain doing the same thing, yes, it takes a bit of time to basically achieve that pain relief, but patients are sustaining that out. We've so far tracked them to the 1 year mark. I'll also highlight this purple line on the graph. And again, this is data from our own NHS. And again, it's really reassuring that actually their scores are better than so their independent data is better than our company generated data, which seldom happens in a lot of clinical trials. But again, there's multiple reasons for this. But in basic terms, when you have patients, these groups here in these blue, orange, and yellow line, the average age is approaching 70. The purple line was average age about 55. Now, age doesn't solely drive success of this treatment, and we've treated those young professional athletes all the way through to people in their 90s and some amazing results. But like anything in life, the younger you are, probably the best you respond to most technologies. Just a couple of bits of information. So again, this is just a bit of data which highlights that from looking at these racehorses and looking at them over 2 years, which is a long-term study for equine species, it shows that effectively over 24 months, joint effusion decreases over time, and that's directly correlated to those horses having less lameness in their assessment, which is really positive. Now, again, a busy slide with lots of lines on this. And why this is relevant and why I've brought this to our attention here is this is taken from the Parker Institute in Copenhagen, which is one of the leading centers for osteoarthritis research. You often see their name alongside papers that's researching many types of drugs or other injectable therapies to try and help with osteoarthritis patients. Now, from their research, they showed that, again, synovitis, that inflammation of your joint lining, plus effusions, that fluid buildup in your joints, can be key signs to potentially improving the success of this treatment. So again, this was comparing against a hyaluronic acid injection, and it showed that those patients that had basically effusion and synovitis had double the impact over those patients that didn't have that in the hyaluronic acid group. The last thing I'll just show is, again, looking at data for younger patients. Again, it doesn't mean that it won't work in people over 70, but when we picked out some data from an RCT, which means randomized controlled trial looking at one therapy against the other, and this was blinded so both the patient and injector weren't sure what the patient was having, it shows that at 1 year in the under 70 group, there's a statistically significant difference in pain reduction. So the HA group had 14 points of reduction in pain, and the arthrosamid arm had 21 points reduction in WOMAC pain. And again, if I think back to the other graph I showed of all the different lines, it's reassuring and nice to see that the NHS data, when they had over 20 points of pain reduction in the younger cohort, is very similar to this data. So again, it's consistently doing the same thing across broad groups of patients. I think that's the point where my slides have ended, but again, very happy to sort of answer questions as we move forward as well. Thanks very much.
Thank you very much, both of you, for sharing your slides and a very informative presentation from you both there. As mentioned, we will move on to the Q&A part of the session. We have received a few while you've both been talking, but I know, Mr. Oni, that you've got a couple in front of you that you probably would prefer to address first, and then we can move on to perhaps me asking you some as well.
I do. And so there's a host of questions I think that were sent in before, and I think we've answered some of these, but one of the ones that I wanted to look at was is this a once only procedure, or can it be repeated when the effects wear off? And the answer to that is it doesn't have to be a once only procedure. It can be repeated when the effects wear off, but I'm sure most people agree that that's only worth doing if you do get significant success from the first injection. And I believe Jonathan could probably tell us that the latest in Denmark at the moment, I believe that some people have had their third round of injections over an over 10-year period of no other therapy and no other treatment, and still going strong in terms of reduction in symptoms from their arthritis. So it's very much something that you can do again, but obviously only if it works well.
Yeah, absolutely. And I'll just jump on that. And when we've met some of the patients or first patients have been injected with this technology over in Denmark, again, they've had multiple years of pain relief. They've gone back to have another injection of arthrosmid and a successful injection on the second time. Now, again, we just don't have a clinical study to show you on this. It's anecdotal evidence. But again, there's no reason why you can't have another injection later down the line. But again, you go back to your orthopedic consultant, be assessed with your knee, then make that shared decision making if this is the right treatment for you at this time point in your life as well. But again, it's amazing when I go to the factory and multiple people's friends, family members have all been treated, and many people that work with an organization have been treated with this gel as they've seen the impact on friends and family members as well.
Bro, thanks, Jonathan. So there's another question here that says, I'm 58 with mild to moderate osteoarthritis in the knee, which is limiting my activity. I enjoy fitness, sport, and my mental well-being and interests centered around being physically active. Could I go back to walking longer and running after arthrosamid? That's very much sounding like an ideal sort of candidate for this. Someone who is younger than 70, someone who has mild and moderate osteoarthritis and active, and looking to not to stay active. Obviously, that like we've discussed, there are other elements to it, but the answer is absolutely yes. That would be someone who would be a very good candidate for the injection.
Yeah, absolutely. I'll jump on that and say that we're
Yeah.
very keen and passionate that, I mean, again, you carry on doing the activities you want to do. Our motto is move freely, live fully. And that's because with osteoarthritis, one of the challenges, not only does it stop you enjoying your life and doing the activities, but also it's a massive burden because then when you're less active, other sort of health issues can start to sort of arise, like cardiovascular issues, weight gain, mental health challenges. And again, we've treated an absolute array of patients, from current very high-low athletes all the way through to most people that just want to enjoy a game of tennis or a round of golf as they progress their life as well. So it's super important to be able to offer that to patients.
Mm.
And again, we've got a rehabilitation program which once you come into the order to be treated, you'll be handed a specific rehabilitation program which has various levels for you as a patient to make sure you're set at the right level for yourself. Or you can work with a physical therapist, and the aim is to get you active and get you moving. And there's very limited downtime from having the injection for you as a patient.
Excellent. Thanks, Jonathan. There's another question here that says, I'm 75. Will I be considered for arthrosamid? The answer is yes. In a word, in more than a word, I know we've talked a lot about age and that being a factor towards how likely this treatment is to work. But as we've also mentioned, there are other factors that are key to this. And so again, this falls within the realms of coming to see someone like myself and being assessed for all those other factors, and then we can have a discussion as to how likely going forward it would be. So there's no one sort of age that I would that would discount anyone for arthrosamid. Like Jonathan said, there are lots of people all the way up to 90 that have had this and done extremely well. The first patient that I ever injected this in had both of his knees done, and he was well into his 80s and couldn't have a knee replacement for other reasons, and he did extremely well, and has not had to have any other treatment so far, and we're 18 months down the line. So it's very much age is just a number, as they say. Let's have a look, see if there's another question on here.
And I was looking, I've seen that there's a question about the NHS. So yeah, no, it's
Yeah.
not available in the NHS at this moment in time. The NHS are very interested because they want to offer patients with options, but again, they've got to be within the financial sort of structure they work within. So again, they are doing a program to assess the potential cost savings this can offer them. But again, to be available in the NHS, there's been some trials which have happened. There is some ongoing clinical work happening within the NHS, but it's certainly not something, unfortunately, for those that's going to be widely available. So again, it would be the likes of going to the Horder Centre to seek treatment to have this as a self-funding patient, unfortunately. That will be something we hope in the future might change, but again, that time scale is not unfortunately months, it's going to be multiple years. But yeah, so it has been used in the NHS, but that's under clinical conditions and trials, not under, unfortunately, use when you walk in to have a consultation of the street.
There's a question on here that says, after arthrosamid injection, is it possible to break the structural meshing that has taken place in the joint? And the answer to that is we have to think about arthrosamid and the incorporation of arthrosamid into the lining of the joint as something that's microscopic. That it isn't they're not large building blocks that can be dismantled or taken apart. And so once that, I like the way Jonathan described it. It's a sort of the filtration sieve system that the lining of the joint has. Once that embeds within that, it's there. And so there's nothing that can break that bond or knock it away, as it were.
Yeah, completely correct. And when we have to go to market and the regulators who give you the license run extensive testing on a product's safety and its biocompatibility, and there's various tests which actually are housed on our website as well. But one of those is like, yeah, how robust is it? And effectively, the way we manufacture the gel, the compound, the material. I mean, we have to do tests like almost you put it into a blender, it can't still destroy the gel. It's called viscoelastics. It's very strongly bound. So again, there's no conditions that you'll find within your own human knee that would destroy that mesh. It's very biocompatible and favorable to the environment that you have within your own knee and body.
Fantastic.
There's a
I'm just looking at, sorry, I was just going
Sorry,
to say, I'm
Karen.
just going to go through them if that helps you out, because I can
Yeah,
push that live for you.
yeah.
So can you have the injection if you've raised calcium level?
So from my point of view, I mean, Jonathan will correct me if I'm wrong. I don't believe there's any issues with the raised calcium level and arthrosamid. Arthrosamid is very much it's a benign inert material that does not sort of interact in a sort of chemical way. And one of the interesting things actually is going down to the factory in Copenhagen and seeing how it's made. Was watching how they stress the material in lots of different ways with different chemicals at different acidity levels and pHs, both naturally what the body will come across and what the body won't come across, and just trying to essentially make this chemical do something, or not chemical, sorry, make arthrosamid do something, as it were, and they couldn't, and they can't, and this is years and years of trying to do that. So it's very much inert. So I don't believe there will be an issue with raised calcium.
Great, thank you very much. Bit more of a developed one here. I'm 68 and very active. I have had cartilage removed from one knee, which I expect will require replacement, but I can manage with it as it is for now. Knee pain varies from day to day and is not consistent. Would this help delay further wear and tear of the joint? Will continuing this level of activity impact the longevity of the treatment?
So that's an interesting one, really, really, and I always talk to people about the difference between the symptoms from arthritis, um, and um, and the worsening of the actual physical arthritis. Now, there are lots of scenarios where people have arthritis that looks a certain way, say looks really bad on an X-ray, and they don't have much in the way of symptoms, and vice versa. The arthrosamid treatment is very much a symptom control. So it may not be, it's not designed to slow down the progress primarily. It's very much designed primarily to improve the symptoms that whatever level of arthritis that you have is getting. That you're getting from that. Having said that, we know that it works within that pain cycle, and so if it slows down the ability of the body to keep that inflammation sort of cycle, then in theory, it really can reduce the amount of enzymes and chemicals that are produced to break down further cartilage. Absolutely. But the focus really for us as surgeons is regardless of how bad it looks on an X-ray, it's all about how it feels, and very much arthrosamid is focused on giving pain relief for a longer period of time, regardless of what might be happening behind the scenes.
Yeah, 100%. And I agree. And if we had a treatment that basically improved your x-rays but gave you no pain relief, that's not something you'd want as a patient, as appealing as it might sound. Unless it provides you with pain relief, that's where you're coming to have some treatment with a clinician. And again, I'll also introduce you. We know that when you look at sort of radiographs, your x-rays, actually, it's not a direct correlation between the severity on the x-ray grading and also pain. So again, we know there's more structural things and substances that go on within that knee joint space. And again, like Mr. Oni said, we're trying to manage your pain symptoms and allow it to regain function. And again, that's why things like rehabilitation is absolutely key, because if we can decrease inflammation in that joint, get you back in some really good quality rehab, allow you to have better muscular control, then again, you have a better result of any treatment, but this included. We're trying to control your pain by doing it in that way of the injection.
Absolutely. Thank you. I know you mentioned about recovery, but specific one here. Do you have to wait after the injection before you can get out on the tennis court again?
So I'll take this one, Jonathan. So what we tend to advise patients is to live life as normal without high levels of activity for the first 2 weeks. After which then you can return back to the activities that you were doing before. In fact, the arthrosamid injection comes with a rehabilitation program and exercises to do. So that's very much encouraged. But in the first couple of weeks, mainly to control one of the side effects of it, which is a flare. Now, it's not a side effect per se. It's essentially that your body recognizing the fact that there is another material in your knee, and initially having a response that means that often people feel it as pain, but usually that sort of dissipates over a week or two. Now, what we wouldn't want in that period is to have a high level of activity which could drive that. And so what we would say is 2 weeks of normal activities without high intensity, and then you can return back to what you would like to do alongside the rehabilitation program.
Of course. Okay. One here, we said, I have osteoporosis. Would this be a problem when having arthrosamid?
I don't believe so. No. So osteoporosis is thinning of the bones, making it more likely, for instance, for breaks or fractures. Osteoarthritis is very much a joint disease, as we've described, and there's no real overlap. So there's no effect that the arthrosamid has on having thin bones.
Does this need to be done using ultrasound?
So the answer is no. So there are different sort of schools of thought, and it's very much surgeon dependent or operator dependent, because there are some individuals that aren't surgeons that do this. Personally, I don't use ultrasound, and the reason for that is my experience is the knee joint is the biggest joint in the body. I have a consistent way of making sure I'm in the joint, which is to take the fluid out of the joint, which can't reside anywhere else. It's something that's personally, in my experience, I've done over 1,000 times. So it's not something that has to be done over ultrasound at all.
General or local anesthetic for the injection?
Very much local. So Jonathan touched on what the sort of protocol of what happens on the day. So on the day of the procedure, individuals come in and have antibiotics, the actual procedure is performed in a treatment room as an outpatient day case procedure, where we prepare the knee, clean the surfaces, deliver some local anesthetic to numb the skin and slightly deeper tissues, and then the injection is delivered. So it's very much not. It doesn't introduce the idea of the risk of general anesthetic.
Fantastic. Another one here that says, is it necessary to do preparatory work, i.e. build up muscle as one would with a knee replacement?
I don't believe it's necessary, although it is certainly beneficial. In the same way as doing physiotherapy is beneficial to osteoarthritis. The reality is, regardless of whatever intervention or treatment that you have for joint issues, the better you are going in before that treatment, then the better you are going out afterwards. So it's certainly advisable to do that.
Yeah, and I can say that when we did the clinical work, that the patients weren't given like loads of rehabilitation sessions alongside that in the clinical work. But again, it makes absolute sense, as Mr. Oni says, the better health you can get your knee in, the stronger you can be, the better for any intervention you'll be in a place to have as well. So I would recommend, if possible, to try and strengthen before and absolutely certainly afterwards when your rehabilitation phase is kicking in as well.
Very important. Thank you very much. We've got a question here regarding cost. So on our website, we've got a breakdown of two costs. One, which is for a single knee injection. It's 2,884 and both knees from 5,132. I will note the initial consultation fee is charged separately, but the cost that I just quoted is the cost of the injection and the procedure carried out by the consultant as well. So back to a few more in-depth questions. I've suffered from dislocation of my knees, aged 14 years of one knee, 20 years of age for the other knee. Over time, my knees have affected my involvement in sports. Now I find I'm seriously reduced in my ability to walk far. I'm age 72. Is this likely to work for me? Perhaps similar answer that you provided, not sure.
I believe, unfortunately, in that question, there's a lot else to tease out before we before we can sort of commit one way or the other. The mechanism of arriving at arthritis is not relevant in that whether it was because of the dislocations or whether it was just wear and tear or whether it was just you're just unfortunate or family history. None of that matters how you get to the state of being in arthritis. But once that pathology happens, then you get fed into all of what we've talked about before in terms of the likelihood of working, and that's a combination of the age, the swelling in the knee and all the other things that we've spoken about. So I think unfortunately that with that individual, it's something that we'd have to have a discussion about in person.
Okay. Perhaps similar answer to this because obviously they're very specific. But obviously, if you've got the opportunity, I'm sure people like to ask the question. So I have a gamma nail in the left femur, which I prefer to retain as I have osteoporosis. I need a new joint. Is arthrosamid suitable for this knee? If not, my right knee is also arthritic, and I hope this treatment will be suitable as I have pain radiating laterally towards my ankle. I'm 73 years of age, very active, walking, cycling, and in the gym. I'm taking paracetamol, anti-inflammatory treatments, and my activities are now restricted.
So I would agree with you, Katie, that very much falls in line with the previous one. There's a lot to unpack. Just by having a gamma nail, it doesn't rule out the treatment. Like we said with osteoporosis or anything like that, the key things are the specifics of the likelihood of working, which we will know after a thorough examination and consultation in terms of severity, in terms of body mass index, all those things that filter into it. So that's something that we need a little bit more from.
Okay. I have a total knee replacement. Could I have this treatment in the other knee?
Yes. So the one thing at the moment it is not licensed for is having an injection in the same knee as a total knee replacement. For some people who've come to see me with wear and tear in the kneecap where the kneecap hasn't been changed in the total knee replacement procedure, that's certainly something not licensed, but it doesn't affect our ability to do an injection in another joint.
Okay. Perhaps some reassurance for this one. What can go wrong? I need this, but I'm terrified of the idea of any sort of invasive procedure now, having had a number of successful surgeries on other bits of my body.
What can go wrong? So I mean, Jonathan will probably tell me anything else that I need to add, but usually when I consent my patients, really we talk about the key thing, which is, excessive bleeding into the joint or infection, both of which are extremely rare. We are yet to see a single case of that in the year and a half that we've been doing it here at the Horder Centre. And I don't think I've had a single case of it, and I've been doing it for longer than that. So it's not surprising because after all, it's an injection, it's a jab. And so it's not something that carries a huge amount of risk. Um, so it's yeah, it's possible, just really, really not probable. And in terms of having successful surgeries or being apprehensive about it, um, I suppose the answer to that is to come and see me, and hopefully I'll put those fears to bed.
Absolutely.
Yeah, and it's proven from the 26,000 knees, 15 years worth of use, but also the other syringes that got into humans and horses over that 25-year history, a very safe, biocompatible, well-tolerated product. So again, it's got a very safe, good safety profile. But like anything, any medical intervention does carry risk, but the risks are very, very low with this treatment.
Thank you. We've got time for just probably a couple more. I have to take blood thinners. Is it okay to have this injection? Also, I'm very sensitive to drugs. Could there be side effects as with all/any medications?
The first thing to say is not all blood thinners are made the same. So there are some that we would worry about more than others. There are some that we might plan around in terms of potentially maybe stopping it for a period. And this falls within the specific niche of the individual therapy and the individual that's behind the therapy as well. So it's not something that we would rule out immediately. And so what was the second half of that question? I missed that.
Oh, also, I'm very sensitive to drugs. Could there be any side effects as with all/any medication?
So again, I think this falls into the realms of the side effects. It's just not probable, and it goes back to what I said about this being an inert product. It is not. It is not a drug. It is not a chemical. It's very much a structure that you're injected into the knee. So it's extremely unlikely compared to any other form of drugs, for instance.
Okay. We've had a couple of repeat questions, so we'll probably end it on a bit of an overview of consultation with you. So the question is, what is involved in the consultation to decide whether or not the treatment is appropriate?
Firstly, the same thing that's involved in all my consultations, which is to take a history of how things developed, form a full, I suppose, story around the knee, get imaging if need be, and then try and piece it all together to see if the individual is an ideal candidate, and if they're not an ideal candidate, what their specific risks are and their specific not just needs, I suppose, but also what their specific likelihood is that this treatment works for them, and we will have a shared consultation and come up with a way forward. So that's generally the way I tend to do things, rather than being a bit more didactic about it in terms of saying to people that yes, you can, or no, you are not able to. It's more of a discussion around the facts and building the story.
Fantastic. That's probably the best place to leave it on, given the time that we have. So thank you both very much, obviously, for your presentations, but for also going through those many questions. We've got a lot more, so I'm sorry if we didn't get through to any that you've submitted. Obviously, thank you very much for joining us this evening. If you did want to have those questions clarified, or just to get in touch, or to book a consultation with Mr. Oni here at the Horder Centre, please do get in touch with us. The telephone number was mentioned earlier on, but it is 01892 600 865, and the email address is the letters PP, so that's Papa at horder.co.uk, and we'll be in touch with you. Also, just when you receive the recording of tonight's online talk, you'll also receive a survey just to get some feedback from you about how this evening went. But once again, thank you all very much for your time, and enjoy the rest of your evening.
Thank you. Good night, everyone.